Well, I'm glad that you all could be here today. You got the title and the aspects, and I'm really wanting to look at a little broader perspective than the project that I did along with Dr. Matzke here from VCU and with our colleagues down at Corelli. We'll talk a bit about that, but in the context of the CMS Innovation Center Awardees experiences. Since some of that information is now available. So, our objectives will be to summarize the evidence regarding the value that clinical pharmacists have provided who have been involved in direct patient care, to kind of set the tone for why did some of these projects come about. I'll describe the healthcare delivery models which were developed and evaluated by these 6 Innovation Center awardees. They're not all the same, they're markedly different. And so when one thinks of the evidence, oh, is there going to be an overwhelming aspect of reinforcement of the same part? You'll find out. We're going to characterize the impact of these care models on clinical outcomes, health utilization, and economic outcome metrics. And lastly, talk a little bit about the lessons these provide for the future, whether those are studies of the value or the expansion and adoption of clinical pharmacy services in direct patient care. So, we're going to go back almost a decade, and for some of you this may be new. You think, this is old. I mean, it wasn't yesterday, so this is ancient stuff back in 2010. But at that time, Bridges and Burns was the lead author on this article published in Medical Care, which highlighted a number of things in terms of pharmacist provision of some level of direct intervention, such as, quote unquote, medication therapy management services, disease state management, or education. That was the lumping because the studies that were done that they evaluated were very diverse. The bottom line they came to is that pharmacists lowered risks associated with high cholesterol, blood pressure, and adverse drug effects. Okay? So this was one of the ones that came out at the time. There were a number of other ones that appeared. Scott Gigerson from the United States Public Health Service did a nice summation that's often cited that someone came up with similar sort of assessment of value. And so this kind of sets a tone and a premise of the start of this sort of thing. Not too long after that paper in 2010, another one came out in Health Affairs, which is more of a policy-oriented journal. And the title is a catchy one, Why Pharmacists Belong in the Medical Home. That's where we need to be. Well, why do we need to be there? Well, lead author Marie Smith is an alumnus of VCU and a clinical pharmacist. And she highlighted a number of the aspects along with the co-authors that pharmacists can affect delivery of primary care, since many of the issues in primary care are related to medication therapy. Pharmacists can perform comprehensive therapy reviews, prescribe self-care medications, resolve some medication-related problems. And what I highlighted as a bottom line was that pharmacists should play key roles, and their potential to serve effectively in this role should be evaluated as a part of medical home demonstration projects. Okay, so this is 2010, towards the end of 2010. The Affordable Care Act was relatively recently approved. That Affordable Care Act allocated $10 billion to CMS to look at demonstration projects to improve outcomes of patients and reduce costs to the federal government. Okay, so that was where we were at towards the end of 2010. Subsequently, there's a number of systematic reviews, meta-analyses that provided evidence of the value of clinical pharmacy interventions, whether it was in cardiovascular risk reduction, whether it was in lowering elevated lipid concentrations, improving blood pressure control, and then the last one by one of our own colleagues here, Dr. Zagato, the effectiveness of clinical pharmacy services, an overview of systematic reviews. So we not only have systematic reviews, but now we look at an overview of systematic reviews that tend to suggest that there's some value, okay? So we're sitting here in 2018. What we have to look back at? I want to highlight medication therapy management interventions in that definitional aspect of what MTM is, because there was a study that came out in 2015 by Viswanathan and colleagues that looked at what were the outcomes of these interventions in outpatient settings. This study was funded by AHRP, appeared as an AHRP publication on their website, but then I'll publish in JAMA Internal Medicine. Looked at 61 articles, 44 studies, 20 were randomized, controlled trials, 19 cohort studies, variety of conditions. None of them were targeted. So it wasn't looking at hypertension, it wasn't looking at dyslipidemia, it wasn't looking at diabetes. It was kind of all comers. It was looking at medications. The surfaces were provided face in about 50% of the cases. But I think it's an interesting note as you look at it, that none of the studies measure the effect of MTM on meeting the clinical levels of therapy. Okay? So we're looking at medication management, not looking at necessarily patient outcomes. So what do they find? These are their conclusions. MTM studies were largely practice-based. Surprise, surprise. They varied substantially in usual care comparators, if there were usual care comparators. Oftentimes it was, let's do this, and look, people got better. Okay, people got better, but what about those who in the same area, same time frame, same disease process, did they get better? The intervention elements were often not well detailed, and nor were the patient populations, and they tended to lack, or at least substantiate, that they use appropriate clinical guidelines for the management of these patients. Their suggestion was there was a need for detailed intervention features. That was one of the key aspects that wasn't there. So how can you say an intervention worked when you don't know what the intervention was? Or the fidelity of how it was delivered? You could write up a method and say, this is what we proposed to do, but we weren't able to do it. But yeah, here's our results. So think of the quality of the information that we have coming through here. We also have an aspect that, as they said in a positive tone, that while MTM programs of the future may contribute to coordinated and improved care through delivery in patient-centered medical homes. Okay, so maybe it was that MTM was done in an outpatient setting. It wasn't done in the context of a medical home. Okay, so bottom line conclusion, this is the one that you see on so many research papers. New research needs to be done. We'll likely continue to find, though, inconsistent results unless the studies account for the underlying sources of variability. You got to know what your patient population is, you got to know what your intervention is, and you have to clearly define what your outcome measures are. Now, all of you know that, right? You knew that before you came in the room. But yet, we now are looking back on years and years of data and studies where the assessment is that that wasn't done. So we have some things to do. Subsequently, in 2016, there was a systematic review of pharmacist-led chronic disease management. Okay. Different than MTM. 63 studies evaluated, 40 were randomized controlled trials, about 33,000 patients across all of these various studies. The interventions, so look at what those interventions are. I don't see MTM, I see med monitoring was what was pulled out of them as keywords, medication reviews, disease self-care and support. Okay. So again, factor that in. This is what was defined by these investigators from the studies that they pulled as chronic disease state management. Delivery mode, 37 of the 63, just a little over half were done in person. About a third were by remote or in person as well. And a few of them were only one-time interventions. The outcome measures, we see a difference from the MTM studies, which didn't look at goals. Here, goal attainment was the predominant outcome measure, okay? Patient satisfaction was in there. Impact on hospital admissions and emergency department visits were there at about a third, and the cost of care, at least was stated, in about a third to be evaluated. So, what are the results of these studies? What does this look like? Well, this is one summation slide. There's a bunch of things here. I'll walk you through it, but it suffices for about 4 or 5 tables in the publication. Targeted diabetes, 25 studies. Goal attainment, 11 of 25 improved. Okay, 11 of 25 improved. 5 no change, 1 decline, and 8 it wasn't reported. Let's look at all-cause mortality, kind of a key aspect. 3, no change. Only 3 out of 25 looked at, did you improve this ultimate outcome measure? You might say, well, now that's a long-term sort of process. Well, it is, but you will never get an assessment unless you look at it. What about health services utilization? 25 studies, in two of 25, one of these elements decreased. 14, there was no change, and 9 of them didn't report it. So at least in the management of diabetes, pharmacist-led chronic disease state management doesn't look like the answer. What about dyslipidemia? Well, 6 out of 7 improved in terms of goal attainment. There was none of them that invested mortality, and 1 showed a decrease in health services utilization. High blood pressure, 2/3 improved. 1, no change in mortality. Health services utilization, 2 decreased, 3 increased. 5, no change, and 5 not reported. Okay. Systematic reviews, many systematic reviews. Value, 2 most recent, MTM and Pharmacist-led chronic disease state management. How many people want to sign up? Okay. You want to integrate that service into your, your CEO of a health system? Okay. So all of these things, the reviews come out years after the papers are initially published. And so as we're looking at this evidence, those at CMS had a sense that there was going to need to be something more. There was going to need to be some studies that addressed this in a reasonable fashion. And so they worked off somewhat of the investigator's conclusion that pharmacist-led care was associated with similar utilization as usual care. That improvements were noted in goals. There was no evidence that patient satisfaction was sufficient. And see the buzzword at the bottom, and you're going to provide a job for many of you, further research is needed, okay, to determine whether, as they put it, med adherence, if it increased, which would be associated with goal attainment, would lead to improved clinical outcomes. So I hope you're getting a sense of what are the steps in the process to get to what is important in terms of the outcomes that you measure. So that sets the tone. The CMS Innovation Center funded 6 medication management awardees. They're listed here, and I'll be going through each of them in terms of what their intervention was and a bit of what their results were. There were 3 additional CMMI projects that have a pharmacy component in them, but they were not considered medication management. And so I don't have access to that information of how the Community Care of North Carolina project impacted things, University of Iowa's Transitions of Care project. I've heard results of that, which were not very outstanding. And I have no information on the Christina Care System. So this is a snapshot, but this is the snapshot of what CMS invested in. And what we now have is our look at the future. So let me state that the source of the data I have is what is readily available to all of you. Acumen and their partner Westat were contracted by CMS to do a mixed methods evaluation of these medication management programs. Their criteria that they used is that the patients had to be evaluable, had to be continuously enrolled in Medicare Part A, Part B, and Part D for the year prior to the intervention and the year after the intervention, or the year during the intervention. The results are available online now. The 3rd annual report was published in February of 2016, and the final addendum was published in June of 2017. Okay. Haven't seen any press releases on this, have you? Seen anything in pharmacy journals? Highlight the value? Talk about where we're at? Okay. So I've got new things to share with you. So we'll talk about the methods. First, the University of Pennsylvania HARP Strong program was designed to improve medication adherence and thereby hopefully health outcomes in patients who recently were discharged with an acute MI. Okay. High-risk population. The intervention, as you can see there, designed to increase adherence, and the anticipated results were to improve health outcomes. So what was the intervention? The intervention was the wireless virtual glow cap pill bottle. Now, we've had devices that you could open and would tell you when it opened. Well, they took this a step beyond, that they were electronically monitored pill bottle openings and transmitted in real time a notice to the HARP Strong's electronic portal to say that the patient opened the container. Okay? So you can't tell if the patient took it, but it moved a step from having this done at the patient's home, they might bring it in days or weeks later, to it's real time. And then they would get a notice, the patient would get a notice reinforcing that that's good behavior. Okay? And in addition to reinforcing in real time that was good behavior, for each day that they were adherent, they had a 1 in 10 chance of winning $5 and a 1 in 100 of winning $50 a day for being adherent. Okay, that's their intervention. University of Tennessee Safe Med program. They wanted to improve care transitions. They state that they utilize comprehensive medication management. You have to read to see that they didn't do much of anything in terms of medication management, certainly not comprehensive. They did create a multidisciplinary team that did include pharmacy, nursing, and social work. And the program was based with a hospital interaction and then a follow-up in the community. Now, a few things along the line here. This program was initially intended as a 9-month-long program, interaction over that period of time. However, patients were hesitant to commit to doing 9 months. And so they changed it to a 45-day program during the process of conducting it. Okay? And it did result in a boost in enrollment, but they also found that looking at patients with multiple chronic diseases was problematic, so they reduced it to 1 chronic disease. Okay? So that's a change in how they can, the design. What was their intervention? A community health pharmacist provided a comprehensive medication review at the time of discharge from the hospital. One interaction. And then a pharmacy technician and a practical nurse did a home visit within 72 hours. And that was the substance of the intervention for almost all of the patients. There were some that continued on and would be seen in the community over that 45-day period. But it was a pretty basic intervention. Okay? Pharmacy Society of Wisconsin. Better integrate community pharmacists into clinical care teams, transform the pharmacist role from drug dispenser to drug therapy coordinator manager. Sounds great, right? Major effort. Participating pharmacists would work collectively with members of the healthcare team to focus MTM services on patients with the 4 diseases there. Geriatrics is basically being get rid of meds that are on the beers list, and folks will be better. So, what did it truly look like? Well, they pushed out to community pharmacists, notice that patients needed what they called 2 levels of service. An L1 intervention-based service, which was basically at the time of dispensing. The pharmacist was supposed to review the cost effectiveness of the meds, identify opportunities to change the dose, consult in education, serve an educational role to improve beneficiary adherence, consult on any device associated with the medicine, and review opportunities to add or delete meds. That was their level 1 intervention at the point of patient picking up the prescription. Their level 2 services were a comprehensive med review. Okay? So their level 2 of a comprehensive med review is basically equivalent to Tennessee's intervention at the time of discharge. Okay? Now, 30% of patients refused level 1 point of picking up the prescription intervention. Greater than 50% refused level 2 services. So it's hard, next to impossible, to tell on the information that's there how many patients actually received the intervention. They did enroll 38,000 patients, but we don't know how many of them. Okay. Other factor is 98% of their patients were less than 65. And so if you're thinking from CMS's standpoint of conducting and funding an investigation to look at what they might save for their enrollees in Medicare, okay, following me. So some issues, but you have to understand what the methods are that were utilized. Okay. The IHARP patient care model described here, I've probably shown this slide in more presentations that I want to talk about and share with you, but in essence, the team here looked at the time of hospital encounter. We had about 55% of patients were enrolled while they were in the hospital. We developed an algorithm to identify at-risk patients. They were interviewed by pharmacy investigator staff, and medication care plan or discharge medication list was provided before they went home. So you could say, in a sense, that that's TMR at the time of discharge. The remaining 45% or so were identified by provider referral from within the primary care practice. Either way, point of intervention, identification point, led to interaction in the primary care clinic. We embedded clinical pharmacists in 22 primary care practices throughout Southwest Virginia. There had never been clinical pharmacists in those practices before. The pharmacists contacted the patient within 72 hours of discharge, and they scheduled an in-person comprehensive med review in the primary care practice, and then delivered comprehensive medication management over the subsequent year that patients were engaged. At the time of discharge from the hospital, we also provided to the patient's designated community pharmacy an updated medication list, and anytime the patient was seen in clinic, the primary care pharmacist sent to that community pharmacist another update to what their medications were. The pharmacist from the community pharmacy could send changes in med use or patient condition back to the PCCP. In reality, you really have a one-way arrow that's going from here to here. We got almost nothing going from community pharmacists back, despite the fact that they were provided full access to the electronic health record and the electronic means to communicate via notes back and forth. So in this project, we enrolled 2,678 patients, 2,480 of which were ultimately evaluable, and we'll talk about a bit in the results. I kind of covered the demographics. Most of them are 65 or over, predominantly Caucasians, and you can see the conditions, 80% with hypertension, 76% with hyperlipidemia, and about 56% with diabetes. So pretty sick population. Our matched cohort of patients matched up pretty well with those. What about the University of Southern Cal care process? They are the closest to what the IHARP process is. They go a bit farther. When they first found out what they were proposed on an interaction with Steve Chen, who's now at USC and was the lead investigator from the pharmacy standpoint, was that they looked to identify, as it shows you here, to identify patients who are high-cost patients, frequent utilizers. They did it predominantly in the hospital setting. They had developed an algorithm, much like we had done in the IHARP process, to identify those folks. And they also had a physician referral process. The idea was that that information that would come into the investigative team, they would provide comprehensive medication management. If the treatment goals were received, fine, they go on to follow up at every 2 months or so of check in with them. If not, they did cycle back for a more comprehensive medication management visit. So it was to integrate those comprehensive services. They enrolled 6,000 plus patients, predominantly Hispanic, predominantly non-elderly women. Okay, compare that to what the IHARP population was, which is predominantly elderly, female, over 65. The incidence of the disease entities about the same in terms of hypertension, diabetes, and the high rates of utilization. So patient populations vary, and maybe we don't have the same processes that work as well in one setting as they do in another. But that's the foundation that we have. USC is kind of the closest to where we're at. The last group in terms of this was the farm-to-farm program at the University of Hawaii at Hilo. What they, in essence, looked to do was a transition of care and care coordination. So they added these aspects to the pharmacist role in the hospital. They employed the pharmacists in the hospitals across the health system in the multiple islands of Hawaii. That pharmacist then, when the patient was discharged to home, they hired, if you will, community clinical pharmacists to provide medication management across prescribers and pharmacies for a year after that patient was discharged. Okay? They were not embedded in clinics. They did not have an conventional identity with those practices. They were basically cold calling them to indicate what they saw. So in a sense, this is care coordination, transition, and then medication therapy management. It's hard to tell because they don't really give you enough aspect. What we do know is they gave each of these pharmacists 8 hours of training, okay, which is probably enough to fill out the forms that they need to fill out for the study to be able to do that. Okay? So hopefully you have a sense with this then that we have a vast array of interventions. Globe caps, hospital CMR, a little bit of MTM, L1, L2, CMM and CDSM, etc. Locations, hospitals often, but a lot of community-based. Enrolled patients vary dramatically. Evaluable patients I want to touch on as we move through this. Out of that heart-strong population, you have 1,500, 37 of them were Medicare patients. SafeMed enrolled only 374 patients. 121 were Medicare. Pharmacy Society of Wisconsin, I already mentioned the big numbers, 1,838 were Medicare patients. We enrolled a little over 2,600, 958 were Medicare by their definition. USC 67, only 275 were Medicare patients. And Farm to Farm, 2167, 506 were Medicare. Why are the numbers in parentheses? Well, because as Acumen did the analysis, it applied that Medicare Part A, B, and D. But for reasons that I've never yet been able to figure out, for USC and Farm to Farm, they added in the Medicare Advantage patients that they saw. But they wouldn't do that for us at IHARP. That's why our numbers went down. Okay. So you gotta look at where you're at in terms of what you enroll and what's valuable. Look at the aspect when you total these all up. CMS came up with $42 million to fund these projects. We're not likely to see $42 million come our way again. Well, maybe someone in the back row wants to make a donation. Okay. But other than that, we're not likely to see that. When you look at your cost per valuable patient, it's pretty low here because you got so many, but they weren't really all evaluable, as you'll see. It's a pretty expensive process for a clinical trial. And so as we think to this, remember the MTM systematic review and the pharmacist-led chronic disease state management systematic review, those most recent ones, that said more research is needed. More good research is needed, and good research costs lots of money. And so we're hopefully going to make the best that we can out of the results that we have with these investigations. So here are a quick summary of the results. NS does mean not significant. Heart strong. Not a single thing was significant. Not a single thing was significant. With one exception. The admission rate of the AMI patients was higher in the patients who were treated. And that was the goal, was to reduce that. But it didn't as a whole come across because not all of the patients had acute myocardial infarction. The SafeMed program, the numbers were too low to do any evaluation. So Acumen did nothing. Because remember, their focus at Acumen was they had all the Medicare database. They did propensity matching to create control groups for all of these studies. Okay? Pharmacy Society of Wisconsin, the results are indicated there. There was actually an increase in 30-day admissions, readmissions, that was statistically significant. Medical expenditures actually were statistically significant in terms of the cumulative increase in physician and ancillary service expenditures. Medication adherence, not significant. Probably should just said at this point, none of us had any impact on significantly changing medication adherence. Now, some of these investigations, the baseline rate of adherence was so high, you didn't anticipate that you'd have a hard job getting further increase. But even in the ones that it wasn't, there still was no change there. What did the IHARP project note? Well, we did note that there was a significant reduction in mortality. They did at Acumen. when we looked at the numbers within the realm, the mortality in the 23 counties where the care was delivered from state statistics was about 13% in that time frame that the study was done. The mortality in the IHARP patients was 7%. So, relative risk that, but we know you can't ascribe readily why that was the only thing, multifactorial. But it's the only one that shows mortality change. Did show an increase in hospitalizations in terms of absolute number. Remember that this is an analysis of 699 Medicare patients. We enrolled 1,584 Medicare patients. Okay, so you're looking at a subset. You don't know why they are subsetted other than they were in Part A, B, and D. Okay. The USC program did result in a decrease in 30-day readmissions, but no significant change in any other of the factors. And the farm-to-farm program, not significant or any not evaluable, with one exception, two exceptions, pardon me. They increased the number of hospitalizations and they increased the number of hospital days. So this is all out of the public record. This is what someone who wants to look for it can see and read the details. What do you think they're going to say? Good job. Great interventions. Where do I sign up? Unfortunately, probably not. And unless the person seeing this goes beyond a summary table like this, which I realize because I spent a whole lot of time talking through the details of each of these analyses and the charts and the multiple graphs and things that we do, because there are some caveats that their analysis that they did look really at quarterly trends, okay? And so let's take an example that I find interesting, because it's our IHARP study, we didn't know exactly a little bit more about it in that detail, that the increase in hospitalization was driven by the increase in the first quarter of 2 years worth of data. In the second year of the project, the hospitalization rate went down from 200 per 1,000 per year to 50 per 1,000 per year. But that wasn't how, in their analysis of how they looked at the data. So I don't want to paint a negative picture. I want to paint a cautious picture to make sure that you look at what was done in the analysis, who did the analysis, in the hows and the constraints that they had with it, okay? So there may be much more that can be gotten out of this, but someone's going to have to do it. Someone's going to have to do it. Because Acumen got paid. They're done. Okay? Good group of people. I didn't have any challenges or problems with them in terms of aspects of their great skills. So let's look at the Investigator published or presented results. Okay? So 4 of the 6 projects have shared the results of their analyses: USC, Hawaii, Tennessee, and Curley and VCU group. Caveat, note that there are often different numbers of patients with different characteristics than those evaluated by Acumen. So this isn't saying Acumen said this, USC said this, who's right or who's wrong. They're different, okay? They're different. The clinical outcome information, however, was rarely available in the results that have been published so far or presented. Right? And we need to make that caveat. Because as you look here, this is the USC information. What is the source of the information? It's a news article in the American Journal of Hospital Health System Pharmacists back in 2016. Okay? Nothing has been published as of yet in a peer-reviewed journal. I've tried to contact Steve Chen multiple times prior to this to help, I want to share with folks, Steve, what have you guys done? Where are you at? And I have nothing further from Steve, so I can only share what is there. They did identify 67,000 medication-related problems. Okay? Right there, I should sign on the line, right? If you can identify 67,000 problems, you must be doing great stuff. It's stated here that their preliminary data showed improved patient and provider satisfaction and total cost of care, sustained decrease in systolic blood pressure and diastolic blood pressure of 15 millimeters of mercury, an average drop in 20% of those patients who were poorly controlled on diabetics from getting their A1Cs down below 9, marked reductions in mortality and 30-day hospital readmissions, and a 16 to 18% reduction in hospitalizations. USC is the only one of the 6 groups that provided clinical data to Acumen to look at. So just a point of contrast, quantitative analysis of the USC intervention was unable to identify statistically significant cumulative effects on any claims-based outcomes. Okay? They didn't find anything in that regard. In terms of clinical outcomes, there was a statistically overall decrease in the rate of patients with uncontrolled LDL, limited evidence of effects on hemoglobin A1C. The interpretation was not associated with a statistically significant change in systolic or diastolic blood pressure relative to controls. I don't know. Some of you guys heard Steve Chin talk. I have difficulty even in placing it in perspective because I can't understand where things are. There's a need. There's a need for all of us in this room and all of us in the profession to be able to make the best out of what we have here. I think they did some wonderful things in talking with Steve, but I don't have anything to stand on to make that case. Where we're at with the Farm to Farm program from Hawaii, Hilo. This is a graphic from their paper in Journal of American Geriatric Society. This is baseline medication-related hospital admissions. Okay, so Acumen looked at hospital admissions, all cause for everybody. Here they look at medication-related hospital admissions. And the red line is the 5 hospitals, starting with 1 to 2 and then 5 ultimately that they're on. So they looked at hospitals as the measure. They didn't look at patients as the measure. And yes, there was a decline in the number of medication-related hospitalizations. When you look at their criteria, the ICD-9 codes that they use for what is a medication-related hospitalization, it's mostly adverse effects, it's rashes, it's things of that type of nature. It isn't where patients better controlled. And so it's different. So the published paper shows that effect. They take that then and they generate an aspect of an estimate of avoided costs. Nice bottom line suggestion is that a reduced cost by $6 million plus. And because their program cost about $1.8 million to administer, it had a 264% return on investment. Okay. It's out there, published. You can utilize it, and it's something that just have to be aware that you're looking at neuropathy due to drugs, contact dermatitis, poisoning, that medication-related admissions might be something that folks look to. But there might be a whole lot of other things that could have, should have, would have been there. And so this is the data we have. This is what we can look to. The Tennessee program, they published that. Remember, Acumen couldn't do any analysis on their data. So what did they publish? But you're going to see them in Jaffa. They published pharmacy technicians as a novel role. Okay. Then they published drug therapy problems and medication discrepancies in 374 patients. And they did an estimate of cost savings. They said in these 374 patients over the period of time they were in, they saved $370,000, or about $900 a patient or so over this time. But it's estimated. Okay? But it is out there. I found, and you read this one on medication discrepancies in the funds, over half of their recommendations were not accepted by the primary care docs that they made the recommendation to. And another 20% weren't accepted by the patients. So nothing more to be said. Okay. Here's the data from the group at Corelli and VCU here. We looked at medication-related problems too. If you're doing a study of this type and you didn't look at medication-related problems, you're really, that's one of the keys to look at. not because it's an endpoint, but because it's a process measure. So there were 18,000 medication-related problems, as you can see, lots of different breakdowns. There were 19,600 pharmacist interventions, the most common of which were get rid of the drug. Get rid of the drug. Then there were add the drug. Then let's get a little more aggressive, and let's change to an alternative, okay? So those are the key ones that came about. So we see medication-related problems in the patient too. You're looking at 18,000 out of 2,000 patients, versus Southern California, 60,000 plus, 6,000 patients. We're looking at about 8 to 10 per patient of the problems that were identified in these time frames. What do the clinical outcomes look like? So, okay, here's our measures. We're looking at 462 patients who had elevated A1C. 10.3, I think, is elevated, is the mean at baseline. I've taken out the standard deviations and the medians and all that because the print became so small that I'm just trying to make a point for you that there were some changes here. And so, highly statistical significant changes in blood pressure, systolic blood pressure, diastolic blood pressure, LDL, and total cholesterol. This is of 2,480 patients who stayed in the program for a year period of time. Okay, so looking from their baseline to where they were at their last observed value. Now, what do these look like over time? Well, you can see there's a relatively prompt decline within 6 months. We didn't do intervals of 1, 3, 4, whatever number of months, but from baseline to 6 months, and then they stayed down over 12 to 18 months or beyond. So it did seem like what was done got done fairly quickly and was persistent in terms of its response, okay, for all of the measures that we're looking at here. What about the comparator population? Okay, here's the IHARP intervention population. Here's our comparator population, another 2,480 patients with similar diagnosed diseases. You can see that, yes, they had changes too. All of these were statistically significant. But the outcomes in the IHARP patients were significantly better in terms of systolic blood pressure and significantly better in terms of total cholesterol. And if I were to talk as an Acumen analyst, it would say something like, they were marginally significant, almost achieved statistical significance for the other three parameters. Okay. But we'll let you look at the data. So, overall, we look like there's value in what was done in the intervention versus the control group from the same region, same makeup as what you're seeing in the intervention group. Now let's look at health services utilization. A little busy. Here's the collaborative care, the intervention group. ED visits increased by 1.3%. This is the cost by which they increased. Okay, this is the estimated cost using reported data in Medicare patients over that time period. Look at hospital admissions. They decreased 23%. This is the cost reduction associated with those hospitalizations. Here's the usual care group. They saw a decrease in ED visits over time, and they saw a decrease in hospitalizations. Okay? So you needed to factor that in. The net result is that we saw savings within the Carilion Clinic population, within the Carilion Clinic hospitals that we can capture of almost $4.7 million. The cost of the program is a little under $1 million, and return on investment is 504%. 504%. We realize that this is not the end all of data. This is in the 1,969 patients that stayed the course for the full year, okay? And we had the prior year's data. But it only reflects ED visits and hospitalizations within Carilion Clinic's 7 hospitals, okay? There's nothing to say that person couldn't go over to Tennessee and get hospitalized at ETSU, or they couldn't come somewhere else. So we are in the midst of analyzing the Medicare data for those patients, because that'll capture that they could have gone anywhere. I don't have the final numbers to share with you on that because Dr. Matzke is still analyzing it, but suffice it to say, the trends are similar. The reduction in hospitalizations is a little bit greater. It's about 31% in the Medicare population. And we actually are seeing slightly decreased numbers of ET visits in that population as well. So, what are the lessons learned? Data collection and archiving are challenging but essential. If you cannot collect your data in real time and you cannot get it in a fashion that you can analyze it, you're up the creek. And so if you're trying to do things manually, if you're trying to do things even in a very simple, let's write an Excel spreadsheet of some sort or a prompt, if you can't incorporate that into the flow of what patients are seeing, you're going to have a grave difficulty in trying to do things with it. Continually monitoring of the data is needed to allow for adjustment. Now, the SafeMed group, that was the ultimate in adjustment, okay? They changed the criteria, changed the intervention, okay? But as you're doing things, realize that when you're going to start an investigation, you're going to give yourself some time that you, and this is called piloting, making sure that it works as good as you thought it was going to work. Access to AMR data was greatly facilitated, but it is not the answer because EMRs aren't designed to be data repositories, okay? They're designed to take care of patients. And if you read much about them or you've worked with them, there's a whole lot of clinicians that feel the only thing they're doing is typing numbers and notes into EMR. They aren't interacting with their patients. So EMR isn't the answer. It's a lot better than paper. But all these tell us the exact aspect. The role of the pharmacist and the primary care team is not apparent to everyone. Everyone here knows that what pharmacists can do, right? You can walk out the door and do it. But think of the Wisconsin experience where 30%, 50%, think of the SafeMed experience. Folks, patients didn't want it. They maybe didn't know what it was, but also on the staff standpoint, what are you going to do? Well, I do that. You're going to do that? Which one of us is going to do that? How, that aspect of what you're going to add has to be an addition, not a duplication. Building relationships are key with patients as well. And adherence is sometimes all about the money. It's all about the time. It's all about the transportation. Okay? And so many of the things on med adherence come by, not that the patient wasn't educated and prepared that they wanted to, but they couldn't get to the pharmacy. They didn't have the money to afford it. And these are key aspects of many of these patient populations. Challenges to wide-scale implementation then. Well, I think first and foremost is the lack of relevant outcome measures. If you're going to sell a program, if you're going to do the right things, is clinical goals improvement enough? Is increased practice efficiency that you can look to because you care for patients that the nurse practitioner, the PA, the physician can care for other patients? Is reduced utilization great? Think about it. You walk across the street to VCU Health System here and you say, I can reduce your hospitalizations, the number of patients coming to your door by 20%. No, I don't think they're clapping. Okay? So you got to know who wants the outcome measure. If you're going to Anthem and you're telling them that you can reduce the hospitalizations on their patient population by 20%, they're going to clap. They're going to sign on, if you will. Because that's savings in their pocket. But the hospitals look like you just took money out of their pocket. Okay? So know who wants what in your outcome measures, in utilization or overall cost. Limited reimbursement avenues and or misaligned financial incentives. This is the one that I continue, and you probably do, in the pharmacy. Well, if someone would just pay me for it, we'd do it. Right? Just pay me and we'll do it. Why am I going to, you got a car, tell a mechanic, I'll pay you $100 a month to keep my car working, okay? And the guy would say, well, but what's the evidence that you're going to keep it working? And that's where the outcome is. So it is a bit about ROI, your return on investment, but that return on investment has to be looked at from the eyes of whoever you're asking or you're looking to be the one involved. Lack of robust electronic health information exchanges. Man, when we started this project with Carillion, we were going to work with the Virginia Health Information Exchange, and we were going to be able to get data from all the hospitals and primary care practices in the state, and that we have a comprehensive look at what the patient care needs were. Where's the Virginia Health Information Exchange? I think it's in the trash can over there, okay? It didn't happen, okay? It didn't happen. The Hawaii exchange happened, and that's why they were able to gather data from across all the islands and the institutions in their islands. So, yes, health information exchanges would help us. Poorly defined interventions and lack of fidelity are clearly another aspect. We can't just talk the MTM language or the CMM language. We've got to get past the acronyms. We've got to say, this is what we consistently do, and we can show you that we did it, and we can show you that when we do it, it delivers value. So I think those are some of the challenges. And lastly, limited patient and provider awareness. I mean, you can offer services. I mean, how many of you see those in the newspaper now and then? They get that full page ad, come on, we're going to do this ultrasonic scan of you and we'll give you your heart risk and all that. Somebody pays to get that done, okay? Because they value it. When you have 50% plus of patients not wanting to engage with their pharmacist and others, clearly we've got some promotional work to do and some value to have to come about. We're almost there. Last time. Developing a business model is challenging. Only a few have shown a positive return on investment. And some of those that have shown some return on investment are so outlandish, you wonder how that's even possible. CMS healthcare delivery payment models does provide a way for a clinical pharmacist to potentially demonstrate their ability to be a revenue generator. And I know there's been discussions within CPPI that, maybe you don't want to do Medicare wellness visits, but it brings in money. Maybe you don't want to do certain other things. Maybe you shouldn't do certain other things. Maybe you can, but that's not factored into any of these investigations return on investment because we were funded by CMS, we couldn't build them as well. Okay? That I think would have been a conflict of interest of the major report. Health plans are seeking innovations to improve patient care, population health management. They are likely to be receptive, but you got to get in the door. Can you take the information that I've shared with you or started to share with you and build that an evidence base that says these types of services or this type of service, since I take this and this piece and put it in, it's going to be of value to you? And if you do, it's a health plan or health system. And I was struck in this past week or 10 days here with Bon Secours now merging with this health system out of Ohio. And Bon Secours has been a leader and been doing things from a pharmacy, but they're now the small potato that's been taken over. Is that going to stay and stick? And is it going to spread to the bigger? Or is it going to become, well, we do this way, and I don't know. Okay. The current evidence does not provide compelling evidence to drive wide-scale acceptance. I can't come to any other summary and assessment out of what we look at. I wish I could say it's wonderful. I think there are components of it that are wonderful. But we need to be prepared to know the full landscape and be able to then articulate what are the best evidence programs. Because there's lots of evidence, but how is the best evidence program mitigate against those that are not so that we can move this forward? Thank you for your time.
So the first 6 centers in the US, they didn't find any significant effect of the MTM or the coordinated care on cost and health services utilization. I'm interested in understanding what was the follow-up period after the intervention, because some outcomes are just hard to get captured in the system if the follow-up period is only up to 1 or 2 years.
Good question. What are the follow-up periods? CMS provided Acumen with data for the year before and basically the year after. Or in some cases, basically what that year after is the year during the intervention. Okay. So that's as far as they extended the data. Okay. So you've got, remember, some of these interventions were at the point of care, or the point of picking up a prescription. Some are at the point of discharge, and then maybe that. So you had some very small windows of intervention that would then look to have an impact over the subsequent year.
So no study compared it. No study had like a 5-year.
No.
For like
The project was funded for 3 years. Okay, and that gave you, when you found out you were funded, you had to start building your system. You had to start building your training. You had to build your algorithms. You had to build your data collection process. You had to hire your people. And so you basically, just about everybody was rushing to get things so they get launched within 6 to 9 months maybe, and then be able to collect data for at least 3 years.
The second question I had was, did all the patients were Medicare patients, or were they?
No.
So why would CMS be interested in non-Medicare in general? Like, what's the incentive for them to include patients from private plans?
Great question. CMS innovation projects didn't specify that you had to enroll for Medicare patients or Medicaid patients. And so what you see is what folks want to have to get enrollment. Okay. So as you're going along, you can think that it probably would have been perhaps wise from Medicare's standpoint to say we want to focus on Medicare patients because that would give us a larger population of folks. But in their other trials, we're looking at primary care innovations, if you will, in some of their model deliveries and in their payment structures. They're looking at all comers patients. The innovation would have applicability across the ages. They have the data on Medicare patients, so that's what they can analyze. They didn't have or provide access to multiple independent or the individual insurance companies that may have been involved. So that's where we're at with what was given and what was given. Clearly, it was not all Medicare patients. Look at that summary slide. There were some, like USC's, with 6,700 patients, only 275 were Medicare. Thank you. Other questions, comments?
So in the IHARP, well, saw a decrease in all-cause mortality. So that was the all-cause mortality was measured within that year of the.
Yeah, all-cause mortality was looked at like patient deaths in the Acumen was looked with in population, and prior to and after of that population. When we did the investigation, IHARP did the analysis, we didn't have, at the time we did that, we didn't have access to the Medicare data. And as surprising as it might seem, health system records are not very often updated when patients die, okay? And so you really, and if you knew in IHARP that we tracked down those aspects to ascertain if patients had died or not. And we had state statistics of deaths in the region. And so that's what we could compare. But it's as you get into this, some of these things are very surprising, that there isn't a way. Mrs. Jones will say, oh, she died 3 months ago. And of course, she just is a no-show, but it's a challenge.
So that percentage, given that your average age is around 65 plus, or most of your deaths within the older population, or is there a mixture?
I can't recall directly off that statistic. The making for that. I know that we looked at the ranges of age that the state reports for deaths, as well as what we had in our population. But I don't know if they were an exact match. Other questions or comments?
The non-significance of some of the outcomes compared to controls, I thought it was interesting, but I thought what was more interesting was some hospital utilizations actually increased. Was there any context to that? Like, did it increase because the pharmacist identified so many issues with the parent, with the patient's treatment that they had to go back and see a physician, or what what accounts for something like that?
So, if I hear your question, the question is, do the pharmacists do such a good job that they got patients to the emergency department because they were having a life-threatening event in clinic or in a community pharmacy that may have ultimately led to a hospital admission? Okay, so they may have increased ED visits, may have increased hospitalization because of their intervention to identify emerging imminent problems. I have no basis to answer that question. It is one of the suppositions, particularly with ED visits, that early on, some folks have thought that, and this is also in the primary care literature of some of the going to patient-centered medical homes, that patient-centered medical homes have led to more ED visits, that you're getting patients into a care environment. The hospitalization side, I haven't seen that, okay? It's reported as a rationale. We don't have any way to directly look at that at this point in time. So I think it's a great question. Maybe it's a thesis. Maybe it's a publication down the road. Ready?
Do you know if anybody has tried to look at these things? There's all these, I'll call them collaborative models now. If you took one element of it out, does it change the outcomes? Because we all are constructing these things with various team members as part of them. And whatever the usual care is it always absent a pharmacist? Or is it always, I'm just curious whether people have tried to do it the other way. Where if you removed a pharmacist, does it change what the team would do? Or not?
The only thing I'm aware of, and Dave may be chiming in, is that Barry Carter, in some of his hypertension work, he has removed the intervention. And that, looking at some, they did one for 9 months, and then they did another group for 24 months. So the 9-month group, they followed for 24 months, but they couldn't have further intervention. And their results are not recorded on my floppy desk here.
Well, I'm curious because I feel like it's hard to
There's some false
study
blood
this.
pressure control, I know, in that. And there's
Yeah.
other studies, maybe not of equal quality or size, that have also sort of looked at this, well, what happened after we discontinued the intervention, and it suggests that there's a loss of effect. But that's not really been studied in an ideal way. So I don't think it's really been fully answered.
Because I'm not sure any of the disciplines that participate in the care of patients could establish on their own that they are the ones who make all the difference. They might for some groups of patients versus others. And it just gets very complex and messy. And the more I've been reading about these kinds of systems in healthcare and thinking about them as complex and adaptive, that it's very challenging to come up with good designs for studying it.
It definitely is. Yeah, trying to find a relevant control group. You certainly can't do within a practice and randomize in a practice. That will not work because the interaction with staff you cannot rule, separate that out. So you have to do different practices. Okay, and you don't know for sure what the baseline practices, the outcomes of those practices are. And so that becomes a challenge. Challenges can be met. The aspect that was to do it requires that you have to have a lot of information and a lot of ability to go through this. I mean, when we polled, I didn't put it on our demographics, I took it off through the waters, but when we pulled our control group and propensity matched them, we at the time we did it, could match on certain factors, age, gender, presence of multiple chronic diseases, those sorts of things. So then as we get, because the health system, you identified, we had like 15,000 patients, you identify those who you propensity match, and then we'll give you the clinical outcome data and the utilization data. Well, in our IHARP population, even though they were matched on age, matched on gender, matched on health insurer, matched on number of multiple chronic diseases, it was almost twofold higher ED and hospitalizations in our intervention group than it was in the control group. So in one sense, you could say, well, no, you had a lot to work with. The other could say you had a long way to go to come close to what was there.
it's hard to match the severity of illness. Yeah. Numbers of diseases, sure, but
Yeah.
you know, we've been trying to do this by modeling what a control group would look like, because our controls never quite. You get such a skewed group when you're looking at propensity score trying to match them, unless you have thousands and thousands and thousands of people, which Medicare could do. I don't know. I think there's different approaches, but none of us has a really good one, I think, that everyone could turn to and say, this would be a standard sort of a evaluation process that we could say, yes, in fact, there really is or is not a difference.
And I totally agree with you. I think that's one of the points of going through this is that you do have to look at what was done, what was come up. If you don't have a control group or usual care group, that's a red flag. That's like saying I went fishing and I'm a great fisherman and I caught all these fish and nobody, well, yeah, but anybody could have caught them in that stream. They were so stacked together, you could have grabbed them. Okay, so you do have to look at a comparator group. But then, as you're talking and you're bringing up excellent points, look at how that comparator group was constructed, and it shouldn't be a convenience group. No, these were available, so we made them our usual care. And for the implementation science and the science of doing clinical trials is moving forward. We're getting better at it. We've got a ways to go. Any other questions, comments?
Just last question. Any of these groups did all of these studies have like a prevalence-based design? That means anybody with a disease condition was included to begin with, or were they all newly diagnosed patients?
They were not newly diagnosed patients. They were not newly diagnosed. You couldn't enroll the number of patients you needed to enroll with looking at new diagnoses. You're looking at patients come in. And you're also looking at the aspect that, you're wanting to look at thousands of patients. And they weren't all uncontrolled patients. They were patients who had the disease. If you're registered, Patty kind of alluded to, you can search for the disease presence or the diagnosis of the disease, but it's oftentimes difficult to, if not impossible, to get the severity of the disease over time or some time element to be able to deal with that. And so
you can't be sure they never interact with a great pharmacist.
It's like, so you got that to have to look to, but they were not usually diagnosed. They were patients as they presented in hospital. And remember, the designs are ones that you're trying to do. USC, as well as ourselves, and as well as the Hawaii, look to try and identify people when they were in the hospital, that's a point of at-risk population, that they're recently hospitalized. All of us went to them, also adding folks who could be referred from the primary care practice. Part of that patient comes back to the primary care practice and the interactions going on. The doc says, this is great. Mrs. Jones needs this, and Mr. Smith needs this, and this is, and you can't say, no, we're not going to. You're trying to build lots of things into your relationships. But they're great questions. I'll be around for a bit if anybody else has anything else. Glad to talk to you.